Good evening, friends. On behalf of the Governing Committee of CAHO, it's my proud privilege to welcome all of you to this 34th International Webinar Series jointly by CAHO and International Society for Quality-ISQua. CAHO, as you all know, is a not-for-profit society established in 2013 to promote quality, patient safety, and accreditation. Thank you very much for supporting us in this endeavor. And it is with all your help and support that today we have this 34th webinar series. And we are extremely happy that we have our friends from the Imperial College of London, Dr. Nina and Dr. Emma Carter here with us to share about enhancing antimicrobial stewardship and the quality of infection management using linked data. This is an extremely important topic for us as we grapple with the problem of antimicrobial stewardship in our country. And to moderate this session, we have Dr. M N Sivakumar. Sir is a life member of CAHO. He's been closely associated with CAHO, and he's the head of the Institute of Critical Care Medicine, Royal Care Super Specialty Hospital at Coimbatore. He is the General Secretary of the ISCCM Coimbatore chapter, the Indian Society for Critical Care Medicine. He's a life member of several societies, the Indian Society of Critical Care Medicine, the Indian Society for Parenteral and Enteral Nutrition, Indian Society of Anesthesiologists, European Society for Intensive Care Medicine, and Indian Society of Toxicology. He has won several honors and awards, and he's an excellent speaker. And he's going to be moderating the session, and he will be adding his inputs on antimicrobial stewardship in our country. I hand over to Dr. M N Sivakumar to moderate the session and welcome all the participants for this session, the 34th session of the CAHO-ISQua International Webinar Series. I also welcome all our international participants from the 27 countries that they participate for this webinar. Over to you, Sivakumar, sir.
Thank you, Dr. Lallu. I think good evening, everyone. Warm welcome to each and every one of you who are part of this webinar series. At the outset, I'd like to thank CAHO, particularly Dr. Lallu and Dr. Vijay sir for this wonderful opportunity. Being an ICU physician for the last 20 years, I do face the menace of antimicrobial resistance on a day-to-day basis. All specialties, all medical specialties are affected by antimicrobial resistance. The worst affected are critical care, oncology, and transplantation. And though we have been talking about stewardship for many years, for the last 2 decades, I think there is a huge heterogeneity between developed and developing countries in the way it is implemented. Even in countries like India, there is a huge heterogeneity between various parts of the country, and there is a difference in which it is implemented between private and public sectors. And the challenges are in terms of collecting data, collating data, analyzing these data, and probably giving proper feedbacks to the stakeholders. And today, probably the information technology and in future, artificial intelligence are going to play a large role in which the data are collected, analyzed, and probably the feedbacks are shared. And today, to talk on these topics, we have 2 very good speakers, Dr. Nina, who's the research lead for population health policy in National Institute of Health Research and Health Protection Research Unit in Healthcare Associated Infection and Antimicrobial Resistance at Imperial College London. Her work utilizes data linkage and novel analytical methodologies to understand the emergence and transmission of infections and antimicrobial resistance. She also evaluates the clinical and economical outcomes of health intervention. I think this is very pertinent for developing countries like us, and she works with hospital and regional health agencies to improve the surveillance data quality and integration. She has also led projects funded by WHO, UK Department of Health, and UK Security Agency. And she has internationally collaborated with countries like China, South Africa, Pakistan, and India. The other speaker for the day is Emma Carter. She is a second-year PhD student at the same institute, and she is being mentored by Dr. Nina. Her expertise encompasses antimicrobial stewardship, infection management, and data linkage. Her current focus involves utilizing data linkage to comprehensively explore the challenges of antimicrobial stewardship and clinical infection management. She particularly investigates the urinary tract infections in vulnerable populations and such as those in long-term facilities. I am very eager to learn from both of you, like many others here. And with this few words of introduction, I will pass it on to Dr. Nina. Over to you, Dr. Nina.
Thank you very much for the warm welcome and introduction. So my name is Nina Zhu, and I'm really happy to be here with all of you as such a diverse and big audience. And today I'm going to give an overview of our recent work in applying data linkage for enhanced antimicrobial stewardship and infection prevention and control. So I do understand that majority of the audience today are coming from a secondary care setting. But the work we'll be covering today covers both primary and secondary care. And that is kind of like the novelty of linking data across settings. And I do appreciate the majority of the audience will be clinicians or the active practitioners, while ourselves are more kind of research-based. But our research unit has been based in the hospitals, and this is an initial step into implementing something in real life fairly soon. So this is an overview of our talk. I will give a quick introduction of myself and Emma staying here with me as a PhD student. I will give an overview of my team based in Imperial College London, and I will talk about linking data to support AMR research and the current practice in England, and then a proof of concept initiative in Northwest London, which is why we're here today, to share the experience of this new initiative we have locally, and to use linked data to support stewardship evaluation and infection management, and also our current progress on a pilot project. So first of all, about myself, Emma, and also my team here. So I have a very diverse background, mixing bioengineering, epidemiology, and health policy research, and I'm newly qualified as a health economist. So my fields of expertise, including applied data linkage, mathematical modeling, and using data for policy and intervention evaluation, including identify the consequences that are not initially intended. So the recent work includes surveillance for healthcare-associated infection, including the conventional fungal and bacterial infection, but also the nosocomial COVID-19 infection during the pandemic. We are also looking at prescribing and stewardship interventions, and also the micro-level factors or the contextual factors influencing policy for infection prevention and AMR. Emma is currently under my supervision, and in her second year of a PhD. She has a pharmacy. She's a pharmacist by background, has been clinically practiced, and she's quantitatively strong. And her recent work and PhD research is focusing on antimicrobial stewardship and AMR surveillance, and also stewardship interventions focusing on primary care in the UK. So our research unit based in Imperial College, my job kind of cover or span two big research unit. One is more UK facing, is called Health Protection Research Unit, AMR and healthcare associated infection. So the work covers priority pathogen, precision prescribing, practice design, engineering, and then the research team I lead, which is population health and policy, utilizing big data to look at AMR and infection trends, and also evaluate stewardship interventions. So this is a more UK-based facing unit. Meanwhile, we have a Center of Antimicrobial Optimization, or CAHO for short, which is a more global facing research unit, covering three research themes: innovative diagnostics, therapeutic solutions, and data science. And this research consortium is funded by Wellcome Trust. Both units are led by Professor Alison Holmes. Her pictures are here. And also, I do want to mention that within our CAHO consortium, one of the participate site or participating country is India. And our India PI is Professor Sanjeev Singh from Amrita Institute. So now coming to linking data to support antimicrobial resistant research. So I don't want to spend any time here. Everyone here knows how AMR is a huge threat to patient safety, but also it exerts huge burden to health systems and also economic systems globally. And then the newly published Lancet paper estimated the mortality attributable to AMR in 2019 and also the ones that are directly associated and the ones that are directly attributable to AMR. So we know that inappropriate use, including underuse and overuse, is one huge driver for AMR. So stewardship interventions have been implemented to promote appropriate use of antimicrobial drugs. So here we have the research here and also the clinical practice is guided by a concept called whole health economy. So essentially, it's basically saying that the stewardship strategies are shifting away from being implemented in a single healthcare sector or an organization to a more integrated manner, meaning intervention could cover multiple healthcare organizations or across multiple sectors. For example, we have stewardship interventions implemented across primary and secondary care. So the findings from a review published in PLOS Medicine by our colleagues, Dr. Manzi McLeod and Dr. Rahila Ahmed, suggested that the finding of a small numbers of evaluation in high-income countries suggested that prescribing can be reduced in a multi-sectoral integrated AMR approach. I do want to highlight that the small number here, it's not because we only identify small number of study, it's because we can only identify small number of research actually fully evaluate stewardship interventions, and majority of them are actually from high-income countries. So a critical function of the health systems, which is to monitor and evaluate of integrated initiative, require adequate support from adequate data. And that is the major drive of linking data together to support research and also formal evaluation of stewardship intervention. So data linkage is kind of a concept that is self-explanatory. It means linking two pieces of more information together using one or multiple variables, such as patient hospital numbers, patient names, date of birth, and gender, etc., etc. So we have methodologically speaking, we have deterministic linkage, which is exact one-to-one character matching to link variables. Or we have assuming like the data sets we want to link are perfect and matching, and there's a unique identifier universally available across data sets. Or we have probabilistic linkage with which has more certainty. Basically, we are matching cases based on more than one criteria, and because we don't have a universal identifier. So, for example, we can match cases based on hospital admission date and date of birth, or date of birth and gender, etc. So this is not a perfect method, but sometimes it can be useful. So two typical kind of like steps or practices in data linkage. First one is deduplication, and second one is imputation. This is just for research purpose, not important. Quickly go through that. So this is a current kind of like practice in terms of the surveillance data available in England or in UK, more general speaking. So if we look at data available within primary care and within secondary care, and then we have data available based on their coverage, we have data set at national level and within regional coverage, and then at local level, meaning covering one or couple more hospitals or one or just a few primary care organizations. And then we have data sets available that is relevant to AMR and stewardship, including the actual prescribing data set or antimicrobial electronic prescriptions. And then we have the surveillance data. Essentially, it's managed by UK Health Security Agency, which is a public health agency in England. And this AMR data set is what we feed into the WHO GLASS system. And then we have also the infection data set that including those are mandatory reporting surveillance for healthcare associated infections. And then in the primary care, we have also syndromic surveillance for flu-like illnesses. So this is all based on symptoms and with no diagnostics or microbiology confirmation. This is for respiratory kind of symptoms only. And then both in primary and secondary care, we also have routine electronic health records. And primary care is for NHS primary care practitioners, and in secondary care is across NHS hospitals. But in primary care, we have data set that is linked at national level, basically basically by that, I mean, we have electronic patient records, the routine records being linked at national level, including like hundreds and hundreds of general practitioners, while in secondary care, we don't have such kind of a linked records available with the same level of granularity. So this is an overview of everything we have in England at the moment. And you can see that while the data set are large and with good level of coverage and granularity, but they are not together, they are not linked together. So sometimes we are restricted by, first of all, if we want to track a patient's journey, we sometimes lost track of them. For example, if we look at someone with infection in primary care, but once they get into hospital, we lose track. Vice versa, we can look at patient cohort in the hospital, but once they are being discharged, we lose a follow-up. So essentially, infection can be chronic and require long-term, but without linked data set, sometimes we don't know what exactly happened to the patient later on during their journey. And therefore, we have a local initiative in Northwest London, which is an infrastructure to allow deterministic individual level linkage across sectors and organizations to support evaluation of stewardship interventions and tracking infections. So this is what we have in Northwest London region, which is a region with 2.5 million population, and more than half of them are coming from minor ethnicity background. So it's a very diverse population. So within the primary care, we have prescribing data, which is electronic prescription collected from general practice pharmacists, etc. And they are linked deterministically with the patient's routine record when they receive care in primary care setting. And then this record has been linked again with their hospital admission records. So essentially, this allows you to follow a patient coming in and out from the community and the hospitals. And at the same time, we have their microbiology test results offered by the pathology survey service in this region, linked with the routine records. So essentially, if a patient seeking care for infection symptoms, and later on we can ascertain whether it's a true infection or it's just because of the symptom. We also know what has been prescribed for the patient. We also know whether later on the patient required hospital admission or reconsultation in primary care setting. So this is essentially the proof of concept initiative we have in our region. And then I'm going to give a few examples of what we have done using this kind of linked data sets. So the name of the data set is called WISIC, Whole Systems Integrated Care. So essentially it's linked clinical and social care records, but also the social care records, including patient demographic and also their admission in care homes, nursing homes, and also the mortality data. It's de-identified for research use through trusted research environment. So it's high level of security. So we also have expanded the linkage with microbiology, as I just mentioned. So it allows assessment of social determinants of health, influencing healthcare, infection, and AMR burden. And the infrastructure is called iCare. So it's actually an initiative that we have developed during the pandemic as a rapid pandemic response. So it's a real-time routine clinical and laboratory data de-identified for research. So it creates tests and evaluate clinical interventions and also linked with social care and also primary care sector data. So this is, first of all, an example of what we did using this kind of linked data set to look at healthcare associated burden during the pandemic level. So we also monitor vaccination level among clinicians during the pandemic, and also the screening and laboratory capacity. So essentially what we're showing here is, while the shaded background showing the COVID and non-COVID admission, and you can see there's a dip in kind of during the first COVID wave, and there's another dip in terms of level of admission during the second pandemic wave. And the solid lines at front are the healthcare associated infection, which is hospital onset bacteremia caused by bacteria during the pandemic. And you can see they shoot up quite dramatically during the pandemic, and suggesting that higher burden on healthcare and also jeopardized IPC practice in our local healthcare settings. So this is a kind of like a real monitoring we kind of like knew that straight away using this data infrastructure, and it allow us to feedback this to our local hospital managers and clinicians for more targeted IPC practice during the pandemic. But also it allow us to monitor real-time the laboratory capacity, because during COVID, all the testing has been focusing on SARS-CoV-2. But by monitoring the number of specimens we're processing every day in our labs, we know that whether we could maintain screening and testing for other bacteria and fungal pathogens. And another kind of example is the work we have done using the same kind of like a data set to look at cluster or outbreaks of non-sarcomial COVID cases and newly emerged multi-drug resistant infection caused by coronary striatum bacteria. So we know that when there's an outbreak, we want to establish epidemiological link. We normally do whole genome sequencing, which is time consuming and expensive. However, with this kind of like a real-time data, this does include patient movement in terms of patient moving in and out from hospital wards and who spend time together. So this kind of patient contact and movement allow us to mapping out their contacts and identify the clusters. And we have confirmed that this kind of outbreak detection using patient movement data actually having similar power compared to more expensive genome sequencing. So it kind of like provide alternative approach in monitoring and detecting outbreaks within hospital setting. So these are the work we have done using the data during COVID. And now coming down to a more kind of like community-based study we have also done. So this is on the figures on the right-hand side are the trends of community onset urinary tract infection, which is a blue line, blue lines above, and also the community onset bacteremia in our region across before and since COVID. And you can see during the pandemic periods, we have decrease in community onset urinary tract infection. So this is individual level data. This is analysis based on individual level data, which is quite powerful in terms of understanding the patient population and also the risk factors. But also it has the similar trends has been also observed using national surveillance data. The only issue is the national data coming nearly half a year later than what we have using the local data. So suggesting that when we have this kind of data infrastructure available, the surveillance and feedback can be much rapid and means more rapid actions can be taken upon addressing any outbreaks and infection, and AMR trends. So that is our kind of like recent works in the past few years based on the linked data sets. And now coming down to a pilot project, which is a work focusing on assessment of clinical and economic burden of community onset or community acquired urinary tract infections. So why we are doing this? First of all, we know that urinary tract infection is highly prevalent, especially among female population. In England, roughly 70 to 80% of female will experience at least one episode of UTI during their lifetime. And also, we know that high level of antibiotic prescribing occurred after UTI, and we know that there's a big proportion of this prescribing is either inappropriate or just completely unnecessary, because we know that UTI is a self-resolving or self-limiting condition. Meanwhile, we do know that there are another portion of UTI has been undertreated, meaning they should have been treated by antibiotics but didn't. Especially this is quite common during COVID when the GP consultation has done remotely or has been remotely or has been suspended completely. So meaning this kind of patient with UTI didn't get treatment they needed, and then later on this infection can be complicated or develop or exacerbated into bloodstream infection. So therefore, the inappropriately treated UTI cause morbidity and even mortality, this including both under and over treating them. And we know that the resistance in gram-negative pathogens, especially E. coli, Klebsiella, and Pseudomonas, are particularly bad. And they are common kind of like UTI causing pathogens. And as I mentioned, there's a changed landscape of care provision since COVID-19. So the current knowledge gap in terms of understanding the clinical and economic burden of UTI include the following points. First of all, it's a diagnostic criteria, because we know that UTI covers a wide range of clinical presentation, especially in the elderly patient. The symptoms can be asymptomatic, so bring these challenges to diagnosing UTI, especially in the settings or the time periods when there's no microbiology cultures. And second is really difficult for us to track recurrent or complicated cases, as I mentioned before, because we are limited by the boundaries of different settings. We lose track of them once the patient being discharged from the hospital, or we lose track of patient in the community when they go to the hospital later. So the evaluation of stewardship interventions for UTI has been restricted to secondary care. So in order to understand that, we have firstly conducted a systematic review and a meta-analysis to look at the economic burden of community onset UTI. So we didn't want to limit our research to look at only the clinical burden, but also we want to understand how much does it cost health systems for this UTI patient just because of AMR. And this is the results. So we can see that the studies, we in total identify 15 studies, and there's a high level of heterogeneity. So we can see that all these studies looking at different pathogens. Some of them look at multi-drug resistant gram-negative bacteremia. Some of them look at MRSA. Some of them looking at 1 or 2 pathogens only, or some of them look at CPE pathogens. So the very high heterogeneity in terms of what kind of pathogen you've been looking at. But overall, we can see that the mortality is definitely higher. The overall mortality is definitely higher in the resistant cohorts compared to the non-resistant cohort. So this is the pooled kind of like results of mortality of community onset UTI, even considering the heterogeneity in the pathogens we're looking at. And a similar finding has been also identified, suggesting that the patient with resistant community acquired UTI also experiences longer lengths of hospital stay. So it's quite interesting because because all these studies are focusing on cohort of community acquired UTI. But at the end of it, the evaluation of patient outcomes and health system outcome are all restricted to hospital setting in terms of the mortality and length of stay. So we don't know what actually happened to the patient who actually didn't admit it to the hospital with community acquired UTI. So all these cases were actually identified within secondary care setting, even the infection was community acquired or community onset. So the findings suggested that there's increased more patient morbidity and mortality associated with AMR and also economic cost as well. Not surprising, but again, it confirmed that the evaluation has been restricted to secondary care. And hence, we have designed our new approach, use the linked data set to capture the economic burden and also the clinical burden associated with AMR in UTI patient in community and also the healthcare and the secondary care. So now I'm going to hand over to Emma, who's going to let you know more detail about this study.
Great. Hi guys. Yeah, so we're sitting together in the room. So let me just, I'm going to be, as part of my PhD, one of my studies is estimating the clinical and economic burden of UTIs caused by resistant gram-negative pathogens. So Nina's given a good overview, but just quickly, UTIs are a common infection, and particularly those in long-term care facilities, and actually the second most common reason for antibiotic prescriptions in the community in England. For gram-negative, so it's mostly gram-negative bacteria, E. coli accounting for over 80% of it, and is an important source of bacteremia. We've also in England, we have issues in terms of trimethoprim resistance. So as you can see on the, we have a high percentage of I think it's about 50% is resistant to trimethoprim. And in particular, long-term care facilities are a particular burden. You have it's a setting with high levels of prescribing and high levels of resistant. And as we were talking about before, we've done this systematic review, and we know that there's a lack of data on the burden in the primary care setting. So what does my study encompass? So we're using UTIs as an example. So we're looking at drug-resistant UTIs from the community, and we're going to be piloting it on long-term care facility residents. So that includes both nursing and care homes. So we're using that as a start to pilot our study, and then we're going to extend it out onto the whole population of North West London. So what we're going to do is we're going to look at the incidence of UTI consultations at GP practices in North West London, the antibiotics prescribed by those GPs, and management of the outcomes. So that will include failed outcomes such as GP readmission, hospital admission, etc. We're going to assess the association between practice level antibiotic prescribing and AMR in UTIs, and investigate the economic cost attributable to resistance. So we're going to go into that further again. So we've got several different data sets. So we have our North West London data set, WISIC. We also have other data sets, including the national level AMR data sets that we'll be using. Again, we'll be piloting. We are lucky in our data set, we have something that identifies people who are in care homes or long-term care facilities, which we'll be using. As it's a smaller data set, it's more manageable, so that we can work out our methodology and our data analysis before extending it out. So as you can see here, we've got our community-acquired pneumonia, and we're looking for further interventions. So potentially somebody's had treatment success, says that they've had no further interventions, or you can have the treatment failure, so reconsultation, prescribing of alternative antibiotics, A&E visit, hospital admission, and all-cause mortality. So that's us looking at our clinical burden. And then we've also got our economic burden, which is the micro costing. But just to go in a bit further, so we're going to be using data linkage of both prescription and GP level event data. So we've got that, and we also are going to be looking, so in that data set, we'll have all about our GP reconsultations, all of our prescription data, but we're also looking at alternative GP consultations for bacteremia, sepsis related to UTIs that are in our data set, as well as looking at the linked with the hospital data to have a look at the A&E, to have a look at the ITU usage as well. So we have restricted our data set to consultations which indicate a community onset lower UTI, and we're using all the primary care diagnoses codes, so that we in England we have something called SNOMED, so it's standardized coding. So we have our SNOMED codes for suspected or uncomplicated UTIs. So then we're looking at our outcomes. So again, unfortunately it's not necessarily linked in terms of a prescription, so we have to use a 7-day leeway of the consultation from the consultation. So 2 days before and 7 days after that prescription will be considered linked to that primary event. And then we've got the windows for treatment failures. So we've got that recurrent UTIs, the bacteremia or sepsis GP consultation or hospital admission. So that's within 60 days, a prescription of a different antibiotic, A&E within 3 days, and our all-cause mortality. And then to further this, so we're going to create our model, and then we're going to add some cost to it. So we are using direct medical costs, which is as per the NICE guidance. And we are in consultation with health economists from the Imperial College Health Partners about doing this micro costing analysis. So we're using the relevant data sets for both primary and secondary care. So luckily they're standardized in terms of costings for things like GP consultations that we'll be able to attribute, give to add to the burden. And then with the secondary care, we've got things like length of stay, as well as costings for the medicines, etc. So just some preliminary results. So we have here that, as you can see here, we've got our time along the bottom, we've got our different years. So it's just interesting to see, because we're going to be doing it from 2016 through to the end of 2022. So that obviously includes the COVID period. So just interestingly, you can see that there is the lighter blue line is 2018, and in 2019 it's the orange line. So you can say they are definitely the pre-COVID years. Then the grey line is 2020, yellow is 2021, and the dark blue is 2022. So as you can see here, there has definitely been a reduction in the number of UTI consultations during the COVID period, and even in the sort of post-pandemic period, as we would call it. And so we haven't seen the recovery, sort of the increase in UTI episodes again, which we thought was super interesting. Yes, and also just that 68% of the UTI episodes were in females. Obviously, in long-term care facilities, you're more likely to have patients with things like catheters, which particularly, for males is a risk factor for urinary tract infections. And around 50% of the UTI episodes were associated with an antibiotic prescription. So, yeah. So that is the end. So I'm going to be handing over back to my colleague Nina as well, and we'll both be able to take any questions.
So thank you, Emma. And then just one last kind of like take-home messages. So we know that this is first of all, this in general, our talk is very research heavy. So what is the implications for policy and also clinical practice? This is a thing that I think is more of an interest of the audience today. And the second is, what is the implication for Indian setting? So we know that pragmatically, there are kind of like studies have been done from India, especially in hospitals. But what is currently going on in the primary care or in the community in general remain a gap, I guess. And also what we are trying to demonstrate here is not just, oh yeah, we have this fancy data set and they're useful. What we are trying to demonstrate that is there is an economic case behind this kind of work. Because yes, we do understand that we need IT capacity or we need infrastructure to bring this kind of a routine practice, to bring this data linkage a routine practice for surveillance and also policy evaluation. But what we are trying to demonstrate here is there is a cost effectiveness case behind this idea, because we know that the patient that acquire infections in the community, unless they are being admitted to the hospital, otherwise the burden happened in the community, this kind of the huge economic cost and morbidity and mortality were not quantified before because lack of data and also proper methodology. And especially we know that within NHS setting in England, it will be easier for us to capture this, while in India and also other countries, there's a huge kind of out-of-pocket payment being done by the patient directly. So whether we can capture this, it's going to be beneficial for both policymakers and also patients themselves. So all we are trying to show today is a methodological primer for anyone or any healthcare setting want to do similar analysis. Because even here, we are doing this at our regional level very, very recently, just because lack of data and also capacity and resources. So it's a very small scale proof of concept initiative we have done regionally here. So it's not easy, and it's certainly not easy to scale up to national level. But all we are trying to show here is there's utility behind this approach, and also it should be a standardized practice and methodology, and it allow us to capture better what is the actual burden of AMR across healthcare settings, and hopefully in long-term future, this can be a routine practice and actually saving the cost and saving the mortality for both healthcare systems and also the patients. So that's all. Welcome any questions. Thank you very much.
Thank you, Nina. Thank you, Emma. I think to set things right, so probably you try to link data through the demographic details, and probably you followed up the patients from a primary care to a secondary care. Am I right?
Yes, that's precise. Yes.
And probably you looked at the clinical and economic benefits. Yeah,
that's essentially the rationale of this work.
Okay. So probably your work was restricted to UTI, or probably you looked at other infections as well?
We have chosen UTI as the first infection condition to look at, just because it's just highly prevalent in England, and also resistant level is quite high. But this methodology, once we develop this, it can be used for any kind of infection.
I think there are a few questions in the, I think I request the participants to put your questions in the Q&A. I think many of you are putting it in the chat box. I think one of it is, I think it's not directly related to this topics, and they want to know about, is there any hurdles you face during implementation of antimicrobial stewardship? I think probably it's not entirely related to this topic. Do you want to answer that?
I'm happy to, though this is not covered by the project, but definitely is something that we also do in our research unit, is looking at the barriers of facilitators and also in general contextual determinants of implementation. So the work we done here, I'm happy to follow up with references of the publication we have done, looking at particularly the barriers and facilitators in terms of the safety culture and climate in the organization, and also the more like the hardware or more the requirement for infrastructure to implement stewardship. So essentially what we find is, first of all, the culture and also organizational slacking. It means like when we throw in too many interventions at the same time, including stewardship, it causes what we call the policy fatigue. So meaning that clinicians are very, very hard for them to kind of like adopt multiple things at the same time. So what we recommend here is we recommend doing this when there's a kind of a slacking in terms of personnel and capacity. And also we recommend doing things jointly. So essentially when we have stewardship, we might join them with kind of like IPC or feedback of surveillance, infection surveillance, etc. So we jointly adopt them together to enhance innovation adoption. But also we do understand the contextual relevance or the contextual determinants in different organizations, and also particularly professional groups. So there's a paper we have published early on by the colleagues, looking at even within the same healthcare setting, there are different level of compliance towards stewardship interventions among different professional groups. For example, nurses are always the ones that taking the initiative and champion the stewardship adoption, while there are other clinician groups or professional groups that kind of lag behind. So essentially what we're suggesting here is, apart from understanding the context, we need to understand the behavior of different professional groups, and also identify those can be the leaders.
Thank you, Nina. The other query is, are the practices of personal hygiene being taken into consideration, especially the difference between those using toilet papers compared those to using water-based cleaning practices in terms of incidence of UTI?
So we don't have this in this particular study, especially we don't have this kind of like measurements towards individual patient. But the work we have had within hospital setting sometimes consider this kind of proxy. So basically during COVID, we have looked at the level of IPC adoption, and we don't have this kind of like measurements towards individual patient level, but we have defined time periods when the guideline of hand hygiene changed. And so we have time periods based on when the guideline changes or when there's new kind of like resources for hand hygiene available. And then we look at how does that influence healthcare associated infection trends within our local hospitals. Okay,
the other aspect we'd like to know from you is, when you looked at the primary practitioners and secondary practitioners data, so is it something to do with your resistance pattern based on the primary practitioners antibiotics, and probably that related to antimicrobial resistance when they were subsequently admitted? Do you see any relation between these two?
Yes, first of all, we definitely have seen different resistant pattern at different kind of like settings. So for example, we in general have multi-drug resistance more prevalent in secondary care, especially those are more invasive, associated with device uses. For example, the patient in ITU with central line inserted. There are higher level of fungal infection in hospital patients as well. And especially during COVID, what we have identified is since COVID, we have newly emerged multi-drug resistant pathogens that identified from healthcare associated infections. We haven't yet identified similar resistant pattern in the community just yet, but we cannot conclude that this did not occur in the community. It's just within the community, we don't have as good monitoring as we have in the hospitals. So again, this is why we need this kind of targeted surveillance, because we don't know whether it means we don't have this AMR pattern at all, or we just wouldn't be able to capture it.
I think you did mention during your lecture, I think you are very early part of your project, but what do you see as a main obstacle when you want to do these kind of analysis, link data in countries like India?
I guess it's more coming down to what is available, even pragmatically, because here we're trying to make this a routine practice. So challenge is more about how do we bring existing data together, and we are bypassing kind of like information governance, and also methodologically we have to link patient one by one. But in India, I do believe it's more about what is already existing, because I do not want to impose any new intervention or you should build new infrastructure, because at the end it's not realistic. I guess it's what we can utilize better, what already being collected. For example, whether there's already existing data, even from a few hospitals or few kind of like healthcare sectors in one region or not. Even we are far away from scaling up just yet, but it's going to be useful if we can look back and just have a reflect on what we already have been collected and how they can be integrated together somehow to answer the question that single data set cannot. And also, in the short-term future, without implementation of new infrastructure, surveillance infrastructure, and then without new resources in terms of capacity building, capacity strengthening, whether adopting a more standardized surveillance method would enhance data collection and reporting. So for example, very simple idea. For example, some hospital would report infection cases while the other hospital would report infection rates. So it's very hard to bring this data together, or sometimes you have periods where you miss surveillance for a short time period. So if we can standardize data collection and reporting, even just across a few hospitals, across few regions, this does not bring additional, this not acquire a lot of additional resources or new infrastructure, but somehow it will make the existing data set much more meaningful, and it allow us to understand a little bit more, especially in terms of the community acquired infections in India. So that's based on my personal observation working with Indian colleagues.
Okay. See, one of the participants want to know what will be your recommendations in order to enhance cost effectiveness in treating community UTI based on your project.
Sorry, could you repeat the last one again?
What will be your recommendations to enhance cost effectiveness in treating community urinary tract infection?
So I guess it's coming down to two parts when considering the cost and effectiveness. Essentially, it's the cost part and the effectiveness part. Because first of all, I think there are key things to consider on both sides. The cost side, we need to capture again better, especially in India when the patient pay out of pocket. We need to define a cohort and follow them properly to capture how much does it expend, not just the direct medical cost, but also the loss of productivity or absenteeism due to UTI symptoms, etc. And then also whether there's a long-term consequences associated with it. For example, recurrent UTI cases, that kind of like you need to follow up patient for maybe a year or so. So that is the first key thing we need to consider. And in terms of effectiveness, we need to define better, because we do not consider only the infection cases we prevented through interventions or stewardship, but also we need to consider how much cost saving per se for the healthcare system. Because well, if we treat treated UTI early on and stop the infection being complicated, it will save us in terms of the hospital capacity, reduce the patient require hospital admission and mortality. So it's kind of two things we need to consider on both sides, the cost and the effectiveness.
The last one will be, I think during Emma's presentation, she did mention that only about 50% of these patients received antibiotics. So the rest of them had asymptomatic bacteria, or why is it so?
So that is kind of like what we expect to say in England, because even in my earlier research, looking at, just following UTI consultation in primary care, we have to know that, first of all, these patients are identified through primary care, so they are still within the community. And that is roughly the proportion of the consultation that will lead to prescribing. Because in England, there's a very aggressive stewardship intervention have been implemented in primary care to reduce prescribing, especially for UTI, because we know that this condition is self-limiting. But we do not just simply reduce prescribing, because we also provide guidance for self-care. For example, tell patient to stay hydrated. We also have interventions such as delayed prescribing. For example, do not unless you don't get better in 48 hours, otherwise you don't need antibiotics, because you can just go home and wait and see. If you still have symptoms in 2 days, come back, I will prescribe. So this kind of intervention must be jointly considered to understand why only half of them received antibiotics. And also the stewardship intervention in England for primary care has been implemented for nearly 7-8 years. So we have made progress in terms of reducing. If you look at data from earlier years, for example, 2017, 2018, the proportion of UTI leads to prescribing is much higher. But for now, we would say roughly 50% of consultation, the patient actually received antibiotics, reflected by the data. So again, we have to understand, if you're analyzing something at population level, data has its limitations. So it's really, again, about interpretation. Yeah.
Thank you, Nina. And the last, I think the last one will be, did you look at diagnostic stewardship also? Was it in the purview of your current pilot project?
So in terms of diagnostic as a stewardship intervention, is that what you're suggesting?
Yeah.
Yes, certainly not myself, but in the CAHO team, in a wider research unit, as I mentioned, but led by Professor Alison Holmes. So it does include innovative diagnostic. So particularly for UTI, what we are trying to achieve is the rapid point of care diagnostic. So we know that the data here, we didn't actually capture this, but in my pilot project, it actually including looking at how many of the UTI consultation has a diagnostic attached to it. So that might include dipsticks, but also urine analysis and microbiology culture. Meanwhile, during COVID, we know that has been significantly reduced because all of the patient has been seen remotely. So now we're trying to look at whether point of care diagnostic can be implemented as an intervention. So now we know it's costly. First of all, we know that, but because it's huge time saving and it can guide prescribing in real-time manner. So we definitely have been looking at, first of all, the sensitivity or the specificity of this kind of rapid point of care diagnostic in primary care, meaning GP can just get it straight away instead of sending the culture for lab and get the results later. But also later on, we do want to do economic evaluation to look at the cost effectiveness. Yes.
Thank you, Nina. Thank you. There are some other queries related to IV line insertion and empirical therapies. Probably we could discuss those things on a different forum. And so if there are no further queries, I would hand it over back to Dr. Arlo.
Thank you very much for that brilliant presentation, both Nina and Emma. We truly appreciate you taking your time for being here with us and for enlightening our audience. And thank you very much, Sivakumar sir, for that wonderful session, moderating it so well, the most appropriate questions, and for giving your time. So as a mark of our appreciation, we would like to present both our speakers with an online certificate which will be sent as email to you. We would certainly love to have you in person, possibly during the upcoming CAHO-Con at Kolkata. Please accept our invitation and try and be with us during April 5th, 6th and 7th. I would request Madam Gracie Mathai, Chairperson of the Kerala State, to hand over the certificate to the two of you. Over to you, Madam.
Lallu. And special thanks to Dr. Nina as well as Dr. Ima. Your presentation was very good, very simple, very understandable, and I think it is highly beneficial to our entire staff who have attended that. So on behalf of CAHO, it's my pleasure to hand over this certificate to you. Dr. Nina, it's my pleasure to hand over the certificate to you.
Thank you. It's my great honor to be here virtually.
And Dr. Ima, it's my pleasure to hand over the certificate to you on behalf of CAHO.
Thank you.
So, thank you once again. Have a great evening and enjoy your day. Thank you so much, everyone, for joining us. Thank you, Sivakumar sir. Thanks to all the speakers, both of you.
Thank you, madam. Thank you very much.